Crohn's disease is not only a bowel disease, it is a systemic inflammatory condition, and its manifestations may appear beyond the gut. The eyes, joints, skin, mouth, liver, and bile ducts can all be involved. So, when assessing Crohn's disease, always think beyond abdominal symptoms. The first step is classification. Not every extra-intestinal finding is a true immune-mediated manifestation. Some findings are classical inflammatory manifestations, some are systemic complications, some are nutritional deficiencies, and some are treatment-related effects. This distinction prevents confusion and guides management. The classical immune-mediated manifestations mainly involve 4 areas: joints, eyes, skin, and oral cavity, and the hepatobiliary system. This simple body map is clinically useful. Think musculoskeletal, ocular, mucocutaneous, and hepatobiliary involvement. Musculoskeletal involvement is one of the most common extraintestinal groups. Peripheral arthritis often affects large joints, is usually asymmetric, and is usually non-erosive. Axial disease, including sacroiliitis and spondyloarthritis, may behave independently of bowel activity. Always ask about inflammatory back pain. Ocular involvement must be taken seriously. Episcleritis is usually milder and may parallel intestinal activity. Uveitis and scleritis can be more serious, may occur independently, and can threaten vision. A painful red eye, photophobia, blurred vision, or visual symptoms should trigger urgent ophthalmology review. Skin and oral findings can give important clues. Aphthous oral ulcers and erythema nodosum often parallel intestinal activity. Pyoderma gangrenosum and Sweet syndrome are important inflammatory skin manifestations. Do not dismiss these lesions as simple infection or trauma without considering inflammatory bowel disease. Hepatobiliary involvement is less common in Crohn's disease than in ulcerative colitis, but it is still important. Think of primary sclerosing cholangitis when liver tests show a cholestatic pattern, especially persistent alkaline phosphatase or gamma-glutamyl transferase elevation. Primary sclerosing cholangitis may run independently of bowel symptoms. A high-yield clinical distinction is whether the manifestation follows bowel activity. Peripheral arthritis, episcleritis, erythema nodosum, and aphthous ulcers often improve when intestinal inflammation improves. But axial spondyloarthritis, uveitis, pyoderma gangrenosum, and primary sclerosing cholangitis may continue despite bowel remission. Not all extraintestinal problems are classical immune manifestations. Crohn's disease can also be associated with iron deficiency, anemia of inflammation, vitamin B12 or folate deficiency, vitamin D deficiency, osteoporosis, renal stones, gallstones, venous thromboembolism, and rarely pulmonary involvement. These are clinically important, but they should be classified correctly. The take-home rule is simple. Classify first. Is it a true immune-mediated manifestation, a systemic complication, a nutritional deficiency, or a drug effect? Never miss a painful red eye, unexplained cholestatic liver tests, or ileal disease with nutritional deficiency. This is how clinicians should think about Crohn's disease beyond the gut.